Dr. Colvin, I'm going to ask you now about the developing knowledge of risk in relation to HIV.
Yes.
Your statement says you became aware of AIDS in 1982. When did you first become aware of reports of infection, AIDS in haemophiliacs?
I think when a report would appear probably in the New England Journal. I mean, I think I may have said what I knew in my statement actually, but I can go back to that statement. But it would have been as soon as it would appear in a journal like the New England, which would have been quite shortly after any announcement by the reports. I would know about it. What I wouldn't, I think, have done would have been to have read the original American report.
Well, we'll just look at that and then we can go through it in a chronological sequence. So could we have, please, Henry, PRSE 40523, please. So this is the MMWR from the Centre for Disease Control, July the 16th, 1982. And we can see the heading, and then we just need to look at the first two lines, I think, two sentences. CDC recently received reports of 3 cases of PCP among patients with haemophilia A and without underlying disease. 2 have died, 1 remains critically ill. Would you have read and received the MMWRs?
No, I wouldn't have seen that report. As I was actually referring to MMWR CDC when I said I wouldn't have seen the original report.
I don't think I've got a particular New England Journal article until the January, but would you expect to have become aware of that through some form or another in the weeks that followed?
I would have thought so.
And then if we could have, please, Henry, HCDO 40556. We can see this is so we're in 1982 here. That report was July 1982. This is the 13th of September 1982.
Sure.
It's a meeting of the UK Haemophilia Centre Directors Hepatitis Working Party. You, of course, were not a member of it, but we can see that Dr. Kernoff was.
Yes. Sure.
And if we go, please, Henry, to the last page, we can see under the heading Acquired Immune Deficiency Syndrome, following discussions at the annual general meeting of Haemophilia Centre Directors. I haven't checked Dr. Colvin to see if you were there. I'll check overnight. But I think you said you generally did attend. It was agreed by the Working Party that as the AIDS syndrome had similarities in its epidemiology to that of hepatitis B virus infection, inquiries would be made by members of the Working Party to ascertain the likelihood of transmission of the disease by blood or blood products. Do you recall any communications or discussions within UK HCDO or between you and Dr. Kernoff around this time about the issue?
No, I don't. But that doesn't mean to say it didn't happen because, it's 40 years ago.
We know that in December of 1982, again, the initial source is the MMWRs, that there was a report of what we've been referring to as the San Francisco baby case.
Yes, I know.
Do you recall learning about that?
No, I don't.
And then we'll come then January 1983 to the New England Journal of Medicine, which I think you would have seen. Henry, PRSE 0002410. So we can see the date here at the top of the page, the 13th of January 83, New England Journal of Medicine, AIDS and Preventive Treatment in Haemophilia. And if we go to the second page, please, Henry. I'll just pick it up at the bottom of the page, where it says this: the fact that haemophiliacs are at risk for AIDS is becoming clear. If the use of cryoprecipitate will minimise this risk, the current home infusion programme needs to be revised. And then the studies reported in this issue demonstrate in vitro abnormalities of immunoregulation, but the numbers are too small for definitive comparison of the risks of different modes of treatment. Unfortunately, the data are consistent with a greater potential for AIDS in the population treated with concentrate. Physicians involved in the care of haemophiliacs must now be alert to this risk. Preventing the complications of the present treatment may have to take precedence over preventing the complications of haemophilia itself. And that's the article by Jane Deforge, which you would have read.
I would think so, yes.
Do you have any recollection of reading it at the time?
My main recollection is my wife's complaint that I used to read the New England Journal of Medicine in bed at this time before I went to sleep. So I think it's entirely possible and likely that I would have read this, because I used to read the New England Journal of Medicine regularly, and this would be an important part. So I can't really conceive that I wouldn't have read it, but I don't recall reading the actual article as of today.
And then in January of 1983, we know you attended a meeting at a London airport hotel. And the reference for that, Henry, is PRSE 0002647. So if we just look at the top of the page to start with, we can see notes of meeting with Immuno at London Airport, 24th of January. And the topic is hepatitis reduced factor 8 and factor 9 concentrates for haemophilia therapy. Could we go to the last page, please, Henry? So we can see there the list of attendees, and we can see a few lines down, it includes your name. Now, do you have any recollection of that meeting and how it came about?
No, I don't.
If we look further up the page, please, Henry. If we go to the previous page, sorry. And we go to the second half under the heading Acquired Immunodeficiency Syndrome. It says this was discussed in the after-lunch period. Dr. Krask summarised the current position. He gave a clinical description of the AIDS syndrome, and then we see further information in relation to that set out in the second paragraph. And then if we keep going down, please, Henry. We pick it up towards the bottom of the page. Up to 10 December 1982, some 800 people had been reported as suffering from the AIDS, and there was a 45% mortality. 10 haemophiliacs in the US have been affected, and 5 have died. The youngest was age 7. All cases have had prolonged treatment with factor 8, but there is no specific implication of one particular product or batch. Other cases involving blood and blood product transmission have included platelets transfused in 3 cases. In one of these cases, one of the donors was a young New York man in his 20s. A second case was a 20-month-old child with rhesus HDN who had received several units, including platelets known to have come from a homosexual donor who was asymptomatic at the time but who later died. The child has developed autoimmune hemolytic anemia and a possible AIDS state. That's the San Francisco baby case. If we go on to the next page, please, Henry. The incubation period for the syndrome appears to be 6 months to 2 years. In the UK, so far, only 1 or 2 cases have been reported from the Communicable Diseases Centre. The infectious precautions include discouraging homosexuals from donating blood or organs. Protocols from the US are being considered by the Hepatitis Working Party in the UK. Apparently, the American fractionation companies are very aware of the problem, undertaking some unspecified measures to screen out such donors. The attention of the meeting was then drawn to the 2 articles, and we've looked at one of them, Dr. Colvin, on the editorial in the New England Journal of Medicine on the 13th of January, which in summary indicates that the T48 ratios among haemophiliacs receiving factor 8 is greater among those who've been exposed to concentrates than those exposed to cryoprecipitate only. However, cryoprecipitate in the US comes from volunteer unpaid donors and therefore are presumably well-motivated people. Final comments on the possible nature of the transmissible agents indicated that there may not be just one agent but a mixture, i.e. a barrage of viruses including hepatitis B, non-A, non-B, CMV and many others possibly transmitted from asymptomatic healthy blood donors. Now I've read that effectively into your evidence because clearly on any view by the 24th of January you would have been up to date with this information.
Yes, sure.
And the attention of those present was expressly being drawn to the New England Journal of Medicine editorial. Can you recall anything about the discussion at that meeting on this issue or
I've
any
already
other?
explained I don't recall the meeting at all.
Oh. Would you accept seeing this material and the New England Journal, and I know you've been following the evidence over the last couple of weeks, that by the beginning of 1983, or in any event by the 24th of January 1983, you would have been aware that there was a risk to haemophiliacs of AIDS?
Yes.
And that the most likely route of transmission of AIDS for haemophiliacs was blood or blood products.
Yes.
We then, if we go to BART 0000679, please. This is if we just zoom in slightly, Henry, thank you. This is a further meeting of the North East Thames Region Association of Haematologists Working Party. It's the 9th of February, so it's not long after the meeting that we've just looked at. You're there, Dr. Kernoff, and others are there. If we just look down over what's discussed, we see there's a discussion about self-sufficiency for factor VIII concentrate production. We look down towards the bottom of the page. There's an issue about cross-charging, and then the end of the page, an aim to produce all factor VIII in the region from local screened donors. And then if we go to the next page, we can see there's then a discussion about designation of haemophilia centres. And then if we go further down, please, Henry, collection of regional statistics, domiciliary haemophilia nursing sister. What's conspicuous by its absence is any discussion of AIDS at that stage locally. Are you able to say why that wasn't by now at least on the agenda, even if not high on the agenda for this working party?
I'm not able to. Perhaps I could make a very brief comment about the previous minute, because one of the features of immunodeficiency in people with haemophilia was thought to be the exposure to factor concentrates of itself. Now, I never did any research in this area at all, but I was aware of those who believed, I think incorrectly, that the exposure to factor VIII itself was immunosuppressive and might have been related to what had happened. Now, of course, I've agreed entirely to what you asked me earlier, but I think there was a sense in which some people thought that there was an intrinsic tendency for factor concentrate to have an effect on immunity.
But whether that explains the non-discussion of the issue at this meeting?
Only in the sense that if people believed that, they might have taken a different view to the one that we've just discussed, and in which case they wouldn't have thought it necessary to talk about this. I think that's unusual and unlikely, but you asked me to think of any reason I could possibly think of as to why this wasn't discussed, and that was the only one I could think of.
But that wasn't a view to which you subscribed, and presumably at some time during the first half of 1983, you must have had some discussions with Dr. Kernoff about AIDS.
That's very likely, that I can't remember the exact dates, because
No.
we spoke together very often.
No, I understand that, but presumably you would recall if he had come up with an unconventional theory about the link with AIDS.
I don't think that Peter particularly had such an unconventional link. All I'm saying is that I knew that around the country there were those who were studying the effect of concentrate on the body's immune system. That's all I'm saying.
May I
Yes,
just ask? I suppose if one treats that as a possibility, and one treats an infectious agent such as a virus as a possibility, the transmission in both cases would occur on either theory through blood products, would it not?
Sorry, could you explain that, sir?
Yes. The risk to which Council has alerted you,
Yes.
discussed at the meeting
Yes.
in January at Heathrow, which you can't remember.
Yes.
Discussed in the New England Journal of Medicine.
Yes.
was a risk of blood products transferring some cause
Yes.
of AIDS to those who are haemophiliac. It doesn't much matter for those purposes, for that analysis, whether the cause was viral or the abnormal proteins found in factor concentrate or whatever, does it?
Well, it would. Let's assume for a moment, which clearly is not the case, that there was something about factor VIII concentrate which inhibited the immune system. Then that of itself could be the cause of an immunodeficiency condition, in which case a virus wouldn't necessarily be involved. I agree that that's not likely, but it was considered. The other possibility is that if it was some kind of virus infection and people have been exposed to a very large amount of concentrate, it might be that those who'd been very heavily exposed to concentrate might be more vulnerable to the immune deficiency illness than those who had not. But, I mean, I'm not trying to say to Councillor Youssef that I don't believe and didn't believe at this point that there was a transmissible agent. I think there was. It's just that Council had asked me whether I could think of any reason why it wasn't discussed at the February meeting.
I think what I was putting to you was
Yes.
that on either view, what was doing it was getting the factor concentrate.
Yes,
That was all I was,
yes, of course.
asking.
And as well as the probability that this was a condition transmissible by blood products or by blood, would you agree that by January 1983, looking at, even if one just looks at the New England Journal and the account given
Yes.
at that meeting at the London Airport Hotel, it was also known at that stage to have a very high mortality rate?
Certainly the condition of AIDS was
Yes.
known to have a high
Yes,
mortality.
sorry.
Yes, of course.
It seemed also to be apparent and is expressly referred to in the notes of the meeting in January 1983 that there may be a significant lapse of time before the symptoms present themselves.
Yes.
So the fact that there were only a few cases at that point identified wouldn't necessarily be a reliable guide to the true extent of the risk.
Exactly.
Can we look at the 1983 returns that you made to UK HCDO? Henry, it should be at HCDO 0000177_003. Thank you. So we can see this is a sample return. These are the annual returns for 1983 of materials used to treat haemophilia A patients, carriers of haemophilia A and von Willebrand's disease patients. Centre is the London Hospital. You're identified as the director. And as I understand it from Dr. Winter, this is a return that would be filled in at the beginning of the following year.
Yes.
So the aim is to give a picture of product usage
Indeed.
During the 1983 calendar
Indeed.
year. And if we look at the figures for haemophilia A patients, total used at hospital inpatients and outpatients, for cryoprecipitate, we've got two figures. One is a figure in packs. Is the other figure that's written there the figure in units?
It might be. I don't know who's written that figure because there's no exact figure that you can put on the number of units, but you might have expected something like 100 or just a bit less than 100 units per pack. So it's not very far off somebody's attempt to work out how many units it might be.
So that's not your handwriting anymore?
I don't believe so, no.
And so we can see that, anyway, you're using cryoprecipitate to that amount. We then have the figure still in the column for hospital treatment for NHS human factor VIII concentrate, 336,645 units. And then we can see the figures in terms of commercial usage. You're using coate to the magnitude of 182,550 units and cryobulin, 108,052 units. So in terms of inpatient usage, it's a mix of NHS factor VIII and commercial factor VIII with some cryoprecipitate.
Yes.
And then if we look at home treatment, we can see that in 1983, there's no cryoprecipitate there identified for home treatment.
Of course.
And we can see the majority then for home treatment is NHS human factor VIII concentrate, 763,747. But there is some factor VIII, some co-8, some haemophil, and a slightly larger amount of cryoprecipitate being used for home treatment.
Yep.
And then if we just look across, for the sake of completeness, we've got for carriers of haemophilia A, you're using DDAVP and tranexamic acid. I think that's only one patient we can see from the top of the page. And then for von Willebrand's disease patients, hospital provision is cryoprecipitate. Seems to be, in fact, the only treatment that's been used there. Is that a correct reading?
That looks correct to me.
9 patients were treated but did not receive blood products. Do you know what that refers to?
It might be patients who perhaps had menstrual difficulties who were given hormone therapy. It might be somebody who came up for something else and perhaps had a wart on their hand and was given treatment for that. I mean, it could be almost anything, but I think it implies that we knew they'd been to the hospital and been consulted, but didn't actually get any particular hemostatic treatment.
And then if we look at...
so hemostatic means things to stop the bleeding.
Yeah. And then if we look at the top of the page, just in terms of the numbers of patients, we've got total number of haemophilia A patients treated during the year 78, carriers of haemophilia A1, von Willebrand's disease patients treated 16. And then if we go to HCDO 0000177 underscore 004, please, Henry. We can see this is the annual return for 1983 of material used for the treatment of haemophilia A patients who have inhibitors. And although the units has been written in the cryoprecipitate column, that's been crossed out and an arrow drawn. So
Yep.
Is it the fair inference that should have been a record of NHS factor VIII concentrate?
Yes, I'm sure it was, but it's a tiny amount. It's hard to know why anybody would be given that amount of NHS concentrate for an inhibitor, because it wouldn't work anyway. But I mean, it's impossible to judge what that means, I think.
And then towards the bottom of the page, we can see porcine factor VIII, the high 8C, 11,000 units.
And at that time, if somebody had a very low titer inhibitor that was responsive to porcine factor VIII, that's what we would have given. What's remarkable in a way in this record for 1983 is that I had almost nobody with an inhibitor who was being treated.
Yes, and of course this is only a snapshot because
Yes.
we don't have returns, I think, in equivalent form for earlier years. If we just look towards the top of that page, we can see in terms of those with inhibitors, that's reference to 2 patients being treated. And then if we can just go to the return in relation to haemophilia B for the same year, HCDO 40177 underscore 005. And we can see here that you've treated 11 haemophilia B patients during the year and 1 carrier of haemophilia B during the year. And then in relation to the haemophilia B patients, both in hospital and for home treatment, the usage is NHS factor IX concentrate. And then there's a small amount of fresh frozen plasma that's been used for the hospital treatment of a carrier of haemophilia B.
That's a rather strange entry, actually, because I'm quite pleased to see it, because it implies that I realised that for a carrier of haemophilia B, there was a risk of infection, and that I was using fresh frozen plasma 3 bags, which only contained the risk of 3 people's infection risk. So I might have decided, and it wouldn't have been the best thing to do, to give a carrier, for whatever reason, I don't know, a factor IX concentrate. It was much better to give those 3 bags of fresh frozen plasma, however out of date such an idea was.
That tells us the products that you were using simply in the calendar year of 1983. Other than the point you've just made about fresh frozen plasma, does what we have seen in those returns suggest any change of approach on your part, or is that essentially consistent with how you had generally been treating patients?
I think it's consistent, not least because I'm relatively pleased to see that it was the case that the majority of my home treatment patients were treated with NHS concentrate, and that we were using some NHS concentrate in the hospital, which was appropriate, but inevitably, because of the shortfall, we were using a significant quantity of commercial concentrate in the hospital. I can't explain the commercial concentrate in the home. It was, I think, about 10% of the total usage. And of course, at this distance, it's impossible for me to tell why that was the case, but it doesn't altogether surprise me.
Now, having understood by January 1983 that there is this risk of AIDS potentially affecting haemophiliacs with high mortality rate and so on, as far as you can recall, did you, in the course of the year that followed, make any changes to your approach to treating patients?
Well, if you look at the paper that I wrote about cryoprecipitate, you will see that the patients who were treated in a rather unusual way with cryoprecipitate were treated between 1982 and 1984. So I think the implication of that is that I was thinking about the risk. And I think that I have to rely on you to tell me when you want me to talk about that paper.
Let me see if I can find the reference to it, Dr. Colvin.
I mention it now only because it shows that I was thinking about it.
Yes, I know we have it somewhere. Maybe I need to come back to that in the morning, Dr. Colvin, because I can't find the reference currently. I can find a reference to a study by you on heat treatment, but I know there is one in relation to usage of cryoprecipitate. So maybe we can put that on screen tomorrow morning. What, if any, recollection do you have of any conscious rethinking of your approach to treatment in 1983?
I think that, again, if one thinks about the little work we did, I think it would have been to try to minimise the risk where it was sensible and possible to do so. But it's very difficult at 40 years' distance to give you a clear view from my memory.
If we, we'll just going through the course of 1983, we can see that in June 1983, you received a letter, as did other directors, from Professors Bloom and Dr. Ritzer. It's BART 0000844. And we can see, Dr. Colvin, this is a letter dated the 24th of June 1983. We've seen it in a similar form sent to others, but this is the version that's actually addressed to Professor
Indeed.
Jenkins and to you. It's headed Acquired Immune Deficiency Syndrome. It refers to a meeting of reference centre directors on the 13th of May 1983 to discuss the problem in haemophilia. And then in the second paragraph, it says this: at the above mentioned meeting on May the 13th, the following general recommendations were agreed. 1, for mildly affected patients with haemophilia A or von Willebrand disease and minor lesions, treatment with DDAVP should be considered because of the increased risk of transmitting hepatitis by means of large pool concentrates in such patients. This is in any case the usual practice of many directors. Would that have been your usual practice in any event at that time?
Yes, it would. I can give you the reference for the cryoprecipitate study if you'd like it now, but perhaps you'd rather tomorrow morning.
Do you have the
It's PRSE
Thank you.
0003838. But yes, it would have been.
Okay, we'll come back to the letter, but I'm happy to look at. the study.
May I? Oh, sorry.
So, yes, so
Yes.
this is the study that you were referring to.
Yes.
A prospective study of cryoprecipitate administration, absence of evidence of virus infection, and the summary of it is in a prospective study of cryoprecipitate administration to patients who had never received large pool concentrates. No evidence of hepatitis or HIV infection was detected in a follow-up period of 1 year. Following the introduction of screening of blood donors for anti-HIV in the UK in October 1985, the use of cryoprecipitate in selected cases should be reconsidered. And I think you had an observation you wanted to make about the...
Can I explain what was happening?
Yes.
Because I think it's really quite important. First of all, this is not really research. What it is an analysis of a clinical decision that I had made on clinical grounds. And you'll see later in the paper that I've said some patients are not suitable for DDAVP. So I had considered using DDAVP in these patients. It's very important because you might say, are you, Dr. Colvin, bringing people to the risk of cryoprecipitate when they could have DDAVP, which wouldn't be ethical? But the position was that there was one patient, I think, with a very severe hematology of the knee with mild haemophilia, and another few patients with von Willebrand's disease who were having elective surgery that I didn't think was appropriate for DDAVP for the reasons that I've explained to you. So for these patients, I would have said to them, this is I think between 82 and 84, I would have said to them, I am concerned about the safety of the concentrates that we need to use for your operation. My view is that for this relatively minor operation, I can use cryoprecipitate to treat you, that there is, of course, a risk of virus infection with cryoprecipitate, and therefore, as we go into do this surgical procedure, I would like to have your consent to take blood samples after the operation to confirm that you haven't had an infection. So this is not research that needs a research ethics approval. It is a study of selected clinical practice. Now, you might say, well, did you give the patients the opportunity to have DDAVP? And the answer is no, I didn't, because I didn't think it was clinically indicated. And I think it's very important for you and Sir Brian to understand what this study actually means. But by the time it was published, cryoprecipitate was dead, because it's published, I think, in 88, or 87, and it's accepted for publication in 86. So by the time it's published, it's actually history. But it shows that I was interested in 82 in trying to keep these particular patients with mild-ish von Willebrand's disease and a bad hematolosis using the concentrate that might be appropriate for this advice.
And if we go back to
before it was given.
Yes. And if we go back to the letter of advice, Henry, so it was BART 00000844. We were looking at the paragraph numbered 1. We just go down a little, Henry, thank you. The mildly affected patients, von Willebrand's minor lesions, treatment with DDAVP. And then if we go to paragraph 2, for treatment of children and mildly affected patients or patients unexposed to imported concentrates, many directors already reserve supplies of NHS concentrates, cryoprecipitated or freeze-dried, and it would be circumspect to continue this policy. We've discussed the existing policy you had in relation to the treatment of children, Dr. Colvin. In terms of patients unexposed to imported concentrates, I think your answer earlier was that in your clinic that would have been largely children in any event. Is that correct?
Sorry, say it again.
Sorry. I'd asked you about whether you had any particular policy for patients who had previously been untreated, and your response, I think, was that those would generally be children.
Probably, yes.
And covered by
yes,
your
I'm
policy
sorry, I understand.
Children.
Yeah.
The category here, we have children, we have mildly affected patients, and then patients unexposed to imported concentrates. So that's not quite completely untreated patients, but
yes.
patients who haven't previously had commercial concentrates. Did you have any particular policy or practice in relation to that category of patients?
So this is the word where the word circumspect becomes very important. And the policy was that if we were going to do major surgery in a patient at that era, then I only had the option of using commercial concentrate.
Would you agree with me that this is a document that is very much leaving matters still to the judgment of the individual haemophilia centre director?
So we've, of course, heard the discussion over the last few days, including Mark Winter's discussion, about the degree to which the UK Haemophilia Centre Directors Organisation and the reference centre directors in particular gave valuable advice. And I think, in retrospect, this advice could have been clearer and more prescriptive. But it is the case that guidelines or advice is only ever guidelines and advice. I mean, from my medical legal experience over many years, I have noticed that many of the problems in medical legal practice are because people haven't perhaps read the guidelines, or more importantly, when they have read the guidelines and have a different view or take a view of interpretation, they don't write it in the notes. I've always been a very keen note writer, and I think my junior staff over the past have got rather tired of me writing notes. But I think it's very difficult, and I would have appreciated more advice from UK CDO. And of course, we haven't yet discussed it, but the Galbraith letter becomes very important in this context, which you may be about to show me.
Well, I may deal with that tomorrow, Dr. Colvin, but just whilst we're still looking at this, would you agree that in the second paragraph, for children mildly affected, those who haven't previously had commercial concentrates, this isn't even saying prioritise cryoprecipitate over factor concentrates. It's saying prioritise NHS, whatever the nature of, whether it's cryoprecipitate or factor concentrates, over commercial.
Yes, it does say that, yes.
In your evidence to the Archer inquiry about this advice, you observed that the advice to give children and mildly affected patients NHS products meant that those who weren't children or weren't mildly affected were probably going to be treated with commercial products. It might mean certain cohorts more likely to receive commercial products than hitherto.
That, of course, is about resource allocation.
Did this advice have any effect upon your policy of using NHS concentrates for home treatment?
I don't think so, no.
And we can see from the return that we looked at, as a matter of fact, you did continue to use commercial concentrates, not to the same extent as NHS concentrates, but still to a reasonably significant degree.
It looks like that. I have obviously have no memory of how or why, but the statistics are the statistics.
So I note the time. I've got a number of further documents I need to explore with Dr. Colvin, so it might be this is a convenient point at which to break and pick it up in the morning.
Yes, certainly we'll do that.
May I make a comment on that document?
This one here?
Yes.
Yes, certainly.
I mean, I have it in front of me. If we go to the bottom of page 1, item 2, it reads, another point concerns the proposed trials of hepatitis-reduced factor concentrates. There is no evidence that the processes involved in the manufacture of these inactivate any other hypothetical viruses. Then it goes on over the page. However, it's still important that the effectiveness of imported hepatitis-reduced concentrates vis-à-vis hepatitis is subjected to formal clinical trials in mild haemophiliacs, notwithstanding our general recommendation above. Directors are urged not, and underlined, to use these concentrates randomly on a named patient basis. That may become important if you were to want to discuss with me Dr. Winter's evidence from his policies in 1984.
Right. Okay, thank you.
Yes, the only other thing, perhaps, if we just go back to the first page of that letter. Can we get back to the previous page, please, Henry? Thank you. And look at the recommendations number 2. there may be a mismatch between what it says literally and how it was meant to be understood. You've understood it as I think it may well have been meant to be understood, that the guidance is for those who are mildly affected or previously unexposed to imported concentrates, they should have cryoprecipitate or NHS freeze-dried concentrate. It actually says many directors already reserve supplies and it will be circumspect to continue this policy. It could be read literally as meaning whatever the directors are currently doing, they go on doing. It doesn't say anything about recommending anything to anyone else.
I think it also implies, sir, that if patients on home treatment were on imported concentrates, they should remain on imported concentrates.
And do you recall, I know I said I'd finish, but picking up on that point, do you recall whether that was the position for your patients?
I don't.
Okay, all right, thank you.
The language is just a bit, if I say mealy-mouthed, it may be misunderstood, but it's not very clear.
I certainly think it was less than helpful now that I think back 40 years.
Yes, thank you very much. Well, tomorrow morning, 10 o'clock, in that case.